which has been sort of the holy grail of nephrologists for all these years. And my previous speaker, he has already spoken about Jaiswal and Rahul. And I suppose my job is to remind others about Rohit and Virat and the role of others. So I'll touch on many molecules. I've been asked to talk on the past, present and future. So I'll just brush your memory on the past agents and what the present agents and what the future holds. So starting with first protein restriction, first proposed in sort of 1991 in the NEJM paper, it was shown in animal models that protein can cause intrarenal vasoconstriction, can increase the intraglomerular pressure. So protein restriction has been attractive. MDRD study, as was discussed previously, has shown that there is a role for protein restriction. Of course, there are some studies which show that may not be of much benefit, but it has sort of stuck over the years. And this is an article from this year, which also suggests that in a meta-analysis that protein restriction along with keto analogs, definitely slows down kidney disease. Next, BP control, which was extensively discussed, of course, a very vital part of the management, and the SPRINT study showed the way. And based on that, an analysis in the renal subpopulation, the KDIGO guidelines suggest a systolic of 120, particularly in proteinuric patients. Of course, with the caution that they can offer less intensive BP lowering therapy in patients with very limited life expectancy or symptomatic postural hypotension. And we are still uncertain of the elderly population, how they'll fare. Sodium bicarbonate, again shown in multiple studies to slow down progression, because metabolic acidosis, as we know, has a deleterious effect in progressive renal disease. Now, of course, the main player of the last decade, where you call it Sachin or Virat, is the RAS inhibitors. Very attractive because obviously the RAS inhibitors takes away the effect of angiotensin II on the efferent arteriole, vasodilates and reduces the intraglomerular pressure. So first, we all remember the captopril studies of 1993 in the NEJM, which showed the way ACE inhibitors ruled sort of in the last part of the last millennium, and the early part of this millennium, it was the ARBs which took over, and this was the famous renal study which showed the advantage of losartan. Now, of course, we got carried away by the enthusiasm and we tried to use both these agents together, but there was a word of caution. The on-target investigator showed us that combining the two only increases the risks of side effects, and hyperkalemia doesn't add too much to the benefit. So after that, we were cautioned against this. And of course, there was another question about using it in advanced kidney disease, stage 4-5, because some studies showed that if you stopped it in stage 4-5, that may cause a temporary improvement in renal function. However, this study published in 2022 in NEJM showed that continuing ACE or ARBs in stage 4, stage 5 slowed down GFR, and if you could manage the hyperkalemia, then this should be done, and you can use it even on dialysis for the cardiac protection. Now we have good agents like patiromer and zirconium to control the potassium, and that is the way things are going in the West already. Next, coming to the present, the most important and besides SGLT2 inhibitors and GLP-1 is MRAs. Now, what is the rationale? How does the MRAs come in? Now, we all know that aldactone increases NADPH oxidase activity, increases the reactive oxygen species and cause pro-inflammatory cytokine release and pro-fibrotic condition in the kidneys, and it's responsible for progression of fibrosis, particularly in diabetic kidney disease. So the rationale came of using aldosterone antagonists. Now we find that with spironolactone, there's an increased incidence of hyperkalemia and also endocrine side effects like gynecomastia, etc. And so there was a yearning for a better agent, and there is where the new kid on the block, Finerenone, comes in. It's a non-steroidal MRA which also decreases the inflammation and fibrosis, the control the hemodynamic factors like spironolactone and the metabolic factors, but with less side effect, lesser hyperkalemia, very minimal or no gynecomastia. So in this regard, the first very important study which was done was the Figaro DKD. You are already aware of these studies. So this was a double-blinded study on type 2 diabetes patients with a follow-up of 3.4 years, and Finerenone was added on top of RAS blockade. And here the primary composite outcome was cardiovascular death, non-fatal MI or hospitalization for heart failure, and the secondary outcome was renal. Now definitely there was a 13% reduction in the cardiovascular outcome, the primary and the secondary outcomes, and subsequently there was the Fidelio DKD trial where the primary endpoint was the renal outcome. The kidney failure sustained decrease of more than 40% in the eGFR or death from renal causes, which my colleague Dr. Shathinath just explained. That's non-cardiovascular but renal causes. And here also there was a significant, 18% decrease of renal progression in the primary composite outcome and 14% decrease in the secondary outcome. So the results of these two trials were combined in the fidelity analysis, and which, when you combine these two trials, we see that the cardiovascular composite comes down by about 14%, and the kidney composite was even better with 23%. And I suppose this is what makes MRAs now one of the pillars of therapy, and Dr. Shathinath mentioned. Now, of course, we were worried about the side effects, but these trials showed that the incidence of major adverse events of moral is similar, AKI was similar, and blood pressure decrease was slight, about 3.2, and gynecomastia was negligible, and hyperkalemia was not that alarming with Finerenone, and it did not result in any of the patients discontinuing the drug. So we could deal with it, the hyperkalemia. So a very, very promising agent to be added on to the ACE and ARBs. And now this study, the confidence trial, has been designed to combine Finerenone with SGLT2 inhibitors, and I suppose that will show us the future strategy. Now, a very important molecule which came up in the middle, because in this field of progression of kidney disease, there have been many molecules. Some have stood their ground and some have been blown away by the winds of time. Now, Bardoxolone maybe is another such molecule. It's a kind of antioxidative action. It binds to KEAP1, and this releases NRF2, and this halts the NF-kappa B and has a cytoprotective action and decreases inflammation as well. So very promising study, the BEAM study, which was published in NEJM, which showed that slowing down of diabetic kidney disease and improvement in GFR at 24 weeks, which persisted till 52 weeks. However, subsequently, the Beacon trial, which was, Bardoxolone tried in stage 4 CKD, it did not reduce ESRD or death from cardiovascular causes. So the enthusiasm kind of waned regarding this agent, but now we have the IAMI study coming up, and this is spearheaded by our present president of International Society of Nephrology, and this will deal with the use of Bardoxolone in a wider GFR range from 15 to 60, as well as significant albuminuria, and maybe it once and for all will give us the answer regarding the status of this molecule. Next, the endothelin antagonist. As we know, that endothelin is one of the most potent vasoconstrictors and its effect on the afferent and efferent arteriole. So one of the first agents in this regard was atrasentan. This is a study published in Lancet, now which showed that endothelin A receptor antagonist definitely reduced albuminuria, but increases the risk of heart failure. So this was the caveat which persisted with the other agent called avosentan. This was the ASCENT study. This was a FDA regulated international multi-center study in which we also participated. Now, definitely, avosentan was also shown to reduce albumin excretion and slow down progression of diabetic nephropathy. But again, the problem with cardiac failure remained, and I suppose further studies are needed with maybe a lower dose of avosentan than what was in the design for the ASCEND study. Next, a very promising agent which has come up of late is sparsentan. This is a dual blocker of endothelin as well as ARB, and that has shown a lot of promise in IgA nephropathy, and this was a study, the DUET trial, which was published in FSGS. Now, we need to see how this agent, which minimizes it causes endothelin antagonism, but with hardly any effect in increasing fluid overload or heart failure. So maybe this may be the promising alternative in future. We are waiting further trials in diabetic and non-diabetic proteinuric disease. Now the JAK-STAT inhibitors, that has also come up of late, that is baricitinib, which blocks JAK1 and JAK2, and due to that it blocks the release of inflammatory cytokines like TNF-alpha and pro-fibrotic cytokines like TGF-beta. And this was a study published in NDT 2018 where baricitinib was seen to slow down progression of diabetic kidney disease. This was a phase 2 trial, and we wait to see how this molecule fares in future. Now, other miscellaneous agents which have been used is first pirfenidone. As you know, pirfenidone is an anti-fibrotic agent, and it lowers the level of TGF-beta and also reduces oxidative stress. Pirfenidone, you must have heard it in the setting of lung disease, ILD, where it shows a lot of benefit. Now, in the setting of kidney disease, it has shown some promise. This was a study published in JASN, and the GFR change in the high dose group was only comparable with placebo. It is possible that the high dropout rate in this group may have diluted any significant observable difference. Despite encouraging results, research into the use of pirfenidone seems to be awaited. Next, again, a very obvious agent, like we know that TGF-beta is one of the main agents which drives the renal fibrosis. And so, obviously, choice would be a blocker of TGF-beta, tranilast. Now, this was a study carried out in early stage diabetic nephropathy with tranilast, which showed some benefit, but again, we don't hear of this molecule again in future. Now, vitamin D analogs, paracalcitol, is also supposed to help by slowing down the progression by blocking pro-fibrogenic agent and also the inflammatory molecule. The association of vitamin D deficiency with DKD risk also supports this therapeutic effect. So future systemic reviews will establish what is the role of these agents. And the future molecules which are being studied, one is abatacept. This is a CTLA-4 Ig. It's a co-stimulatory blockage in patients with B7-1 positive proteinuric kidney disease, and this has shown benefit. This was a study published in NEJM in diabetic and non-diabetic kidney disease. We need to see more results. Another very promising agent, this was a trial presented in the European Congress recently, rancaciguat. It is a soluble guanylate cyclase activator, and this causes improvement in renal blood flow and improvement in GFR, and it demonstrated beneficial effects in patients with CKD and advanced CKD disease, and a reduction in urinary albumin excretion. Again, we need to see what it holds in the future. And again, in the future, we may be seeing more of these epigenetic studies, epigenetic regulators, which have already shown promise in animal studies. So, vorinostat or valproate, histone deacetyl inhibitors. Now, we don't know whether this is the way future things will go. We need to watch the space. And definitely, there are many molecules in the pipeline which are being tried, and the future definitely seems bright in achieving our holy grail. But for the time being, the various associations. That is what the three pillars which have been accepted are the RAS inhibitors, the MRAs and SGLT2Is, and maybe, as Dr. Shotinath mentioned, semaglutide will form the fourth pillar at present. And later on, we just have to watch and see where amongst all these multiple agents which have been tried, we can build more pillars and improve the kidney function and slow down the progression of kidney disease. Thank you.